Country Director. It's nice to meet you all and having you in this webinar in tobacco control challenges and opportunities in global health. As Sambhavi has already described about our initiatives and and in the meanwhile, in the later part of the program, we'll be presenting our program details to all of you. So without any delay, I would like to hand over this floor to Sambhavi to start this program. Thank you.
So we have our participants joining. I think we have few more remaining participants to join this session. So it would be better to wait for a few more minutes and then we will start.
That's fine. Masud and Naima, so Prajwal is my friend. We worked together probably in 2015, right? So that was the course when we went to do a cardiovascular epidemiology course in Fiji. So, and that is the time we started doing and having the connection and all of this. And Prajwal is also the chair of non-communicable disease, World Federation of Public Health Association, and I'm a member of that group. So we have again reconnected. So we are doing some of those collaboration apart from this. Prajwal, you say about yourself, so I should not say about you.
Okay, so myself, Dr. Prozol Pagril, as said by Aziz, we met in 2015 in Fiji for that International Society of Cardiovascular Epidemiology course, and from there onwards we have continued our work. I'm a visiting Lowndes Scholar at Harvard T.H. Chan School of Public Health, and currently I'm the chair of NCD working group at World Federation of Public Health Associations. I'm also a working member at Nepal NCD Alliance and a member of World NCD Federation India. So since last more than 10 years, I've been working in the field of NCDs, and I run my own NCD and mental health campaign where currently I'm trying to design a cluster randomized control trial for the prevention of diabetes in context of Nepal in collaborations with Global Foundations of Community Health and Harvard Medical School. So we are trying to launch that project in context of Nepal. The name of that project is ICE Hall, and we are trying to do that project in context of Nepal, and that is being envisioned to be conducted in 4 countries in Nepal, India, Pakistan, and Mauritius. So I'm the PI of that trial now in context of Nepal. I'm working with this young colleagues. So I want to build the team for NCD prevention, and I'm working with these young colleagues from Nepal Health Course who are very much active. I believe they are very much enthusiastic and eager to learn. And I think and we have been doing this anti-tobacco campaign currently, and we have reached to all the provinces of the country. So I think Samabi will brief at the end of this webinar about our campaign and how we are going on that campaign, and we would love to collaborate with Aziz and his team for this initiative as well. So how we can how we can make more robust on this campaign. So we can discuss on those aspects as well. And we are also we have also started recently we are trying to start an NCD Compass course in context of Nepal. So all the young ambassadors of Nepal Health Course are trying to enroll on that course, and we are trying to do that course in context of Nepal as well. This is my about my introduction. Thank you very much.
Thanks.
Thank you, Aziz.
So it would be really good, probably after the presentation, so you can think of, and we discussed earlier, Masud Prajwal. So the objective of today's talk is really to share what we are doing, but at the same time that will also generate the interest and to give them a little bit more idea whether we can do the same study in Nepal. So probably we can talk about this thing later on. So will we have any introduction later on, or I will allow Masud and Naima to introduce themselves?
I think so. It would be better if they introduce now, because meanwhile we'll be having presentation and question answer sessions. At that time, maybe we will have limited time.
Yeah. Sure. Okay, Masud, let's go first.
Okay. Thank you, Professor Aziz, and such a scholarly background, Dr. Prajwal and Dr. Ayush. Thank you so much for having us from Federation University. So I'm a public health physician. So I did my MBBS long time back and did my post-graduation in public health. I've been working in a public health field for the last 1.5 decades. I have served basically in Bangladesh and before moving to Australia in 2009. So did another master's from University of Melbourne. Sorry, I was hearing some echoes here. And so, and then also worked in public health in the in some of the Asia Pacific countries. And then I'm a student of Professor Aziz now, the final year PhD student, and would very much like to share my final findings with you guys today.
Thanks, Masud.
Thank you.
Naima?
Hi, hello everyone. It's a pleasure to be here today, and I'm very much like enthusiastic for this your global health initiatives. And I'm a PhD student in Federation University. I have my bachelor in dental surgery from Bangladesh. Then I have done my master's. I was involved in teaching in Bangladesh, and also with my PhD, I'm also like doing some teaching and marking at the moment. And it's I'm feeling very good today that you all like in the platform in Nepal, which I visited like when I was student. So I'm feeling like the faces of Nepalese people, and they are very near to me. And when I visited Nepal, I felt like Nepalese people are very friendly. And yeah, thank you so much for having me today.
Thank you, Dr.
Thanks, Naima. Wish that we could be there in person as well. So we need to think of going to Nepal in future.
Yeah, you are welcome. Nepal, we are welcome, and we love to collaborate and work with you, with your team, Aziz. Yeah.
Sure. Okay.
So I think now we'll have to move on to our main agenda, the discussions and the presentations. So I'd like to welcome everyone again. Namaste, good evening. On the behalf of Nepal Health Corps, I would like to extend a warm welcome to all of us here today who have joined this webinar, which is titled "Tobacco Control, Challenges and Opportunities in Global Health." This is Sambhavi, a public health professional, and I will be moderating this webinar today. So this webinar is particularly a part of Nepal Health Corp's ongoing nationwide anti-tobacco campaign, which is, as already explained, a youth-led movement which we have aimed to reduce the tobacco use and to promote a healthier community in Nepal, in all provinces of Nepal. So we are doing this, as already I explained, we are doing this through education sessions, through community outreach, and also through digital advocacies. And this is all, we are doing all this to empower young people so that they can become the champions of tobacco control at grassroots level and prevent the use of tobacco in community and school and colleges settings. So before we begin with our speakers today, I would like to briefly reflect on context, what we have in Nepal and other developing countries. Despite the presence of laws, national laws and policies and increasing awareness efforts, the tobacco use remains a pressing public health challenge, which is fueled by various factors, including the affordability, the widespread availability of tobacco products, the cultural acceptance in countries like ours in remote areas where older generation are taking it as cultural ritual, and or most recently, the growing trend of vapes and e-cigarettes among the adolescents. So these are the pressing issues that are fueling up the use of tobacco in our country and in other developing countries. Although we are the signatory of World Framework Convention on Tobacco Control, FCTC, and we have also been awarded by WHO for implementing one of the strongest tobacco packaging law in world, achieving the 100% pictorial health warnings on the tobacco product packaging. This all serves as a powerful tool for public awareness, but also we are lagging somewhere to control the increasing trend of use of tobacco products, especially among young people, especially this vaping and e-cigarettes. So this Nepal also continues to Nepal also continues to face these challenges, and this session we aim to bring the gap between learning from the international experiences, particularly from Australia. And we hope to discover the practical and cultural sensitive solutions that we can get so that we can control the use of tobacco in our region. So we have three speakers today. We have our first speaker, Professor Dr. Mohammad Aziz Rahman, who is a globally recognized public health researcher, a medical doctor, and academic. He serves as the head of public health and research advisor at Federation University Australia, and is also the vice president of Public Health Association of Australia. Today, he will be speaking on the updates on control activities in Australia. So, Professor Rahman, we warmly invite you to begin the session. Thank you.
Thanks, Shambhavi. And I'd like to begin by thanking the Nepal Health Corps to organize this event and inviting us to give us the opportunity to share what's happening in Australia. So let me share my screen. Okay, so you need to give me the permission to share.
So I just did, Dr. Rahman.
Excellent, thank you. Okay, so in my brief talk, what I'm going to do in the next 20 minutes is to talk about really updates on tobacco control in Australia. So I will focus more on what's happening in Australia in terms of tobacco control laws and all of these issues. So before I go to this thing, just to remind you, when we talk about tobacco, definitely we need to remember that we are talking about the active smoking mainly. And when we talk about active smoking, we know that it contains more than 4,000 chemical compounds, and half of them are naturally in tobacco leaf, and half of them are really created when chemical reaction happens, and also manufacturers add some of these things. One of the important part that I'd like to mention is when we really face the challenges for the active smokers to quit smoking, because they are really addicted to this issue. And if you think of the addictiveness of cigarettes, it is more addictive even compared to alcohol or cocaine. So we need to remember this thing is really a highly addictive substance. So smokers who are really long-term smokers, they really need that support. And I'll talk more about this thing later on. The other thing that we shouldn't forget is not only about the active smoking, it's also the passive smoking. And one of the passive smoking is called the secondhand smoking exposure. And I'm pretty sure that all of you are familiar with this thing. And you know, we already have the scientific evidence that secondhand smoking exposure or this passive smoking exposure impacts both children and adults. And if you look at some of the risk is 25 to 30% more to get coronary heart disease among non-smokers. And even brief exposure can damage lining of blood vessels. So the bottom line is there is no risk-free level of exposure to secondhand smoke. So if you are beside your smoker friend, either it is for a few minutes or a few hours, you are really exposing yourself to the impact of secondhand smoking. So there is no risk-free level. So you need to remember that. Now, let's look at Australia's situation. If you look at the disease burden in Australia, so tobacco is the second leading risk factor for disease burden in Australia. The topmost risk factor is overweight and obesity, and the second one is tobacco use, and you can look at other factors. Now, Australia is doing really good in terms of the tobacco control laws, implementation of laws. And if you look at this diagram, so if you look at the trend, so starting from really more than 20%, it has gone to 8.3% now. So current smoking prevalence nationally in Australia is 8.3%. So it's really good. It is really promising. And all of these things are really the credits for the tobacco control advocates, tobacco control policy implementation, and all of these things. And as somebody was mentioning something about the implementation, what I've seen specifically in the developing countries, sometimes the laws are there, but the implementation is not there. So when the implementation is not there, probably it's not that effective. So as a whole, smoking prevalence is really good in 8.3. And if you look at the females and males, you can look at the proportion here. Now, within this thing, we also need to think of the people who will start smoking. So the latest data is showing the first cigarette smoked by the people, the age was 16.6 years. So that has pushed a bit more. So if you look at the previous data, so it was a bit less. People started smoking earlier. Now the latest data is showing people don't start smoking before age of 16.6 years. So that is really good. Now, if I look at this thing, so as I mentioned, 8.3 was really good nationally, but when you look at the variations of smoking, And if you look at this thing, 20.4%, so that is the smoking prevalence in the remote areas. So it is not universal across all the geographical location in Australia. So in the remote areas, the prevalence is really almost 3 times. And people who are living in that socially disadvantaged location, they are 3 times more likely to be smoker compared to those who are really living in the most advantaged socioeconomic status. And indigenous population, their prevalence is about 29%. So although we say that it is really good in terms of smoking prevalence nationally, but there are variations, there are challenges. Indigenous population, people from socioeconomic status, people from remote areas, they have high prevalence of smoking. I would like to share a few data from our recent studies and the national survey. So you can see some of those information here. I will not go to all of these things, but there has been definitely as the current smoker has gone down, so that means never smoker has gone up. And people in their 40s and 50s were the most likely to smoke daily. So if you look at who are the people who are smoking daily, so that is at the age of 40 or 50s. But the concern is some of this thing, it is really tragic in Australian setting. 1 in 10 mothers smoked at any time during pregnancy. So that is a big concern, although it has gone down from 13%, but still it is a concern that pregnant women smoke in Australia. Passive smoking exposure, it has gone down, but still people are exposed to passive smoking in Australia. And if you look at the reasons for smokers that they mentioned about trying to quit smoking, and one of the top reasons that they have mentioned is costing too much money. So that is an important point we need to think of. So if the price of the smoking and the cigarettes go up, so definitely that will impact on the behavior of the smokers. So they have also mentioned it is costing really too much. In terms of the different efforts, so counseling was the most common treatment type that most of the, almost 1 in 3 episodes, counseling was the most common main treatment that the smokers have used. Now, as we have mentioned about vaping, Shambhavi, so vaping is a big concern in Australia. And if you look at this national data in 2016, it was only 0.5%. In 2019, it has increased to 1.1%. And in 2022-2023, it has gone to 3.5%. So if you look at this thing, so it is a growing concern in Australia, so it has increased a lot. And if you look at the age distribution, the main challenge is 18 to 24 years, their prevalence is 9.3%. So young people have started using this vaping, and it is a big concern. So yes, vaping is a growing concern in Australia, and you will hear further about this study from our third speaker, Naima Nimmi. Now, if we look at the smoking and vaping prevalence as a whole in Australia, according to the socioeconomic status, so you can see a disparities. If you look at this thing, smoking prevalence is really high among the least disadvantaged people or people from low socioeconomic status, whereas vaping is more prevalent among the highest socioeconomic status. So there is a disparity between the users of smoking and vaping. Few latest data about vaping. So almost 1 in 2 current smokers had used e-cigarettes in their lifetime. So that means those who are smokers, they have also used vaping. And the most common reason that people have mentioned why they are using vaping, it was curiosity. And that is the thing that's happening among the young people. They are thinking of, okay, let's try this thing. It's a new thing. Sometimes, it's a peer pressure. So people think, oh, if I don't use this thing, I can't be within this group. So they try to do this thing as a curiosity. Lifetime use of e-cigarettes increased significantly. It has increased from 11% to almost 20%. So that is really a significant increase that happened in Australia. So that's as a whole about the smoking and vaping status. Now I'll go to the tobacco control measures. So in terms of tobacco control measures, I'm sure that all of you who are working in tobacco field, you know about this strategy called Empower. So that's called monitoring tobacco use, protecting people from tobacco smoke, offering help to quit tobacco use, warning about the dangers of tobacco, enforcing bans on tobacco advertising, promotion, and sponsorship, and the last one is raising taxes on tobacco. So I will touch base some of those issues, what's happening in Australia. The other thing that I'd like to mention is tobacco industry tactics. Tobacco industry is always active to do their marketing and advertisement. So sometimes they use the direct tactics, marketing and advertisement, but sometimes they use the indirect tactics. We need to remember this thing, like sponsorship, brand stretching, product design, product placement. And sometimes, they also produce lots of scientific literature. So we also need to be careful about the literature that we review on this thing, because if it is sponsored by the tobacco industry, their ultimate aim will be to increase the use of tobacco products. We need to be very careful about the tobacco industry tactics. And just to remind you, this tobacco industry lies because since 1960, tobacco industries have known that nicotine is addictive. But what happened in 1994, they took under oath, and in US court, they have mentioned all the big tobacco company CEO, they have mentioned under oath that tobacco is not addictive. Whereas from 1960, they knew this thing. So this is really, we already have a proof that tobacco industry lies. In 2000, in the pressure of this public, so Philip Morris became the first tobacco company to state that nicotine was addictive publicly. So think of the situation. They knew this thing really long time ago. They lied this thing even under oath, but eventually it came out that they knew this thing. So we can't really rely on whatever they have mentioned. They will mention in terms of sometimes they do this corporate social responsibility. They also try to do some scholarship funding. So we need to be very careful because they are not trustworthy. Now, in terms of success stories, as Shambhavi has also mentioned about the plain packaging and all of this things, so Australia is the first country who implemented this plain packaging, and there's a long story about this thing. Tobacco companies had a strong battle. Eventually, they were defeated and were successful. And in terms of plain packaging, the graphic warnings are there. There is an advertisement ban at the point of sale. So when you go to the shop, you can't see the advertisement. It is banned. It is shaded under a shade. So that is been implemented. There are strong media campaigns about smoking, and there's a smoke-free policies. In terms of tobacco control policies, so feel free to search for National Tobacco Strategy if you want to know a bit more. So we have currently National Tobacco Strategy that's February to 2030. The ultimate aim is to reduce the national daily smoking prevalence to less than 10% by 2025. That we have already achieved, and 1% or less by 2030. So we are working towards this. And reducing the daily smoking rate of the first nation people to 27% on the 2030. So as I mentioned, since 29% of the first nation indigenous people, we are trying to reduce this thing. There is also national preventive health strategy in Australia, and tobacco control is also a key component. One of the latest reform that happened is about vaping. So, among the young people, vaping was really an epidemic in Australia. So what Australian government have done in the last year, and gradually they have done lots of law implementation. And one of the things that they have done, they have mentioned any vaping products, regardless of whether they contain nicotine or not nicotine, cannot be sold anywhere other than the pharmacies. So if you want to buy this thing, you need to go to the pharmacy to buy this thing. Previously, it was really available at any shop. So that has been restricted now. So if I think of the tobacco control legislation, what's in place? So this is really the summary of all of the legislation that's happening. Definitely there's an age limit. It can be sold to anyone below 18 years of age, smoking and vaping. There's an advertisement laws that could not be any advertisement. I will talk a bit more about this thing. There are tobacco packaging laws. You have seen the plain packaging. Taxes, I will talk about this thing. There is smoke-free laws. There's vaping laws. There are smokeless tobacco products is banned in Australia. Although having said this thing, if you go to the Indian Pakistani shop, you can find some of the smokeless tobacco products, but legally it is banned in Australia. Now, in terms of advertising and sponsorship ban, so in Australia, any form of communication or activity that directly or indirectly promotes smoking or vaping, either it is writing, image, audio, video, sign, symbol, trademark, it is banned. So publish for the public to see or hear, including in the internet, film, or products, t-shirt, any type of advertisement that is banned in Australia. So we are doing really good in terms of advertisement ban. So recently I just came from Indonesia. So in Indonesia, it is really devastating situation. I don't know what is the situation in Nepal. So I hope that there is still advertisement is banned there, but in Indonesia, you can see the big billboard with all the smoking advertisement with a cool image that is really prevalent in Indonesia. Tobacco packaging laws, the retail packaging of tobacco, and there's the plain packaging, and you can see this thing, there's a certain features that they need to comply with. They need to have this certain text with the certain color. They should not display any logos, any brand image. And why they have done this plain packaging? Because it prevents misleading or deceiving consumers about the harmful effects. Before it came in place, so tobacco industries used to do different types of deceiving message. Sometimes they mention low nicotine, extra low nicotine, even nicotine-free advertisement in the tobacco pack. That is not true. Sometimes they used to put this thing menthol-free, menthol cigarettes. Sometimes they used to put the attractive color, like pink color, to attract the women. And sometimes, slim is Virginia Slim, and that type of cigarette packs was there to attract the people. And sometimes, they put the candy flavored cigarette packs so to attract the young people. So this plain packaging means you can't advertise any other brand. You can't put this thing in different color. So it reduces the appeal to different market segments. Tobacco taxation, so that is really powerful, and it is important from the country point of view. If government put a tax, and this tax increase prompted many Australian smokers to make quit attempts, reduce their smoking, and make changes to their tobacco purchasing behavior. So it works. Tobacco companies will always try to mention this thing, we give lots of taxes to the government. It is important, but the impact of this is really high compared to the tax that they give to the government. If you think of the health damage, if you think of all of these issues, it is more damaging compared to the amount of money that they provide in tax. And it has been proven scientifically that if the tax increases, cigarette price will increase. And if cigarette price increases, people will change their behavior of purchasing. And the one thing that I should have mentioned, in the developing countries, you can go to a shop, you can buy a single stick of cigarette. In Australia, you can't buy this thing. If you want to buy, you need to buy a full pack. So the full pack of cigarette is really costlier, and the government has increased the tax significantly. And in the recent time, there is also going to have another tax increase on the cigarette pack. So that is really working, and it is really important to handle the tobacco issues in Australia. In terms of smoke-free laws, so it is illegal to smoke in enclosed public place, and these are the public places where it is not possible to smoke, and there is a heavy penalty on this thing. It's not only the laws are there, but there is also implementation of this thing. There's a heavy penalty on this thing. And why it's important you understand this thing? Because it is to protect the people from secondhand smoking, encourage people to quit smoking, and help to denormalize smoking in the community. So there are smoke-free laws, and there's a state implementation of the smoke-free laws. The last thing that I want to mention is about smoking cessation. So these are some of the macro level of effect where the government will put the tax, will put the smoke-free laws. But what about the smokers who are really smoking? So we also need to remember that more than 2/3 of the smokers want to quit. And some of the people who are with the mental health status or substance use, they will also try to quit, and it is the same situation. Even the smoking rate is high among them, but they make more attempts but less likely to succeed. So it is important that we need to support them. And one of the important points is hospitalization or disease diagnosis, and that's called in the literature, it's called teachable moment. When someone is diagnosed with a cardiac disease in the hospital, sadly, they have that fear in their mind that they may die. So that is an important teachable moment where we can work. Where we can work for supporting them to quit smoking. Now, in terms of what works for smoking cessation, many of you probably know about this thing. So just to summarize this, there are different methods, and those are available in Australia. One of these things is pharmacotherapy. One of these things, behavioral intervention. So it is the counseling. We also have quit line. So there is a telephone quit line. Anyone can call this quit line and they can get the customized support. We have the brief intervention by healthcare providers, and healthcare providers are important, powerful professionals who can support patients to quit smoking. And Dr. Masud is going to talk more about this thing. And there is self-help. and there is also quit coach and quit text. So it's not only giving a call, you can also use the text message and they can also help you to quit smoking. And the last thing is about harm reduction approach that's called vaping. So there are some evidence that smokers who are long-term users, probably they may be benefited by switching to vaping as a harm reduction approach. And you will hear a bit more about harm vaping issues from Dr. Naima. Very quickly about the role of health professionals. So we know that patients expect their physicians to actively participate in advising them to quit, but sometimes they are really busy and their expectations do not match. So it is evidence that 1 in 5 unmotivated smokers will make an attempt to quit if advised by their physicians. So it is particularly important because this Nepal Health Corp is working among this young generation of professionals. So it is really important to give them the message. So all of them will be really powerful changing agent and who can work really to help the smokers to quit. Because the patients who are smokers, they expect their physicians or the healthcare professional to talk about smoking. And even not only the doctors, but the nursing intervention have an increased chance of quitting if they are provided. So it's really important. But at the same time, we also need to think of whether the healthcare provider, they also have enough training or not, whether they are capable to provide that cessation support or not. So we also need to think of this. Vaping, and Naima is going to talk more about this thing just briefly. So I'm sure that you have heard lots of things about vaping, but it is not harmless vapor, and it also causes addiction. Sometimes there are some evidence that it is a gateway to smoking. Smoking cessation rule, there is a strong debate on this thing. It causes injury, and it is also harmful to the environment. Public support to control smoking and vaping in Australia, high level of support among the general population in Australia. Most of the people want that there should be ban in advertisement for tobacco products on social media, and they also support the banning of additives or flavoring agents in cigarettes and other tobacco products. They also support prohibiting sale of vaping products to people 18 years of age. The last thing that I want to mention is this is an article that was published in Lancet Public Health recently. If you look at this thing, the people who start smoking, the age of starting smoking, that is the crucial point that we need to work on. And 83% of all smokers began smoking between the age of 14 and 25 years. So that is the time we need to work on all the tobacco control people who are working. If we target this group of people within this time, because that is the time, if we can prevent them to uptake smoking, because they are the future smokers, they will continue their smoking for the lifetime. So if we can do some intervention targeting that age group, that will be really powerful. And many countries are really trying to do this type of activities. Say, for example, in New Zealand, they are really doing, they are trying to work on this thing that sometimes, sometimes later on, there'll be next generation who will be smoke free. So it is really important. It is really encouraging that we work on this young group of people. So the take-home message is tobacco kills too slowly, so therefore there is a lack of urgency. If it is COVID pandemic, so people were really worried about all of these things, but tobacco kills too slowly. Whatever the diseases that you have due to tobacco, that kills too slowly, so therefore there is a lack of urgency. Tobacco companies will always try to use different tactics. We need to be aware and update on these tactics. Smokers need effective support for smoking cessation, and support from health professionals are crucial. E-cigarettes are showing promising results for cessation. However, it do not support normalization of smoking. It can be effective harm reduction approach for smokers, although we need to be very cautious on this thing because we are saying it is effective probably only for the smokers who try different tobacco cessation tactics and then they fail to quit. Then probably vaping is effective, but we need further evidence from cohort study. The last thing that I would like to mention by the quote from the Director General of WHO, if tobacco was a virus, it would long ago have been called a pandemic and the world would marshal every resource to stop it. So we just need to remember this thing because it kills too slowly, therefore it lacks urgency. With this thing, thank you for your attention. Feel free to scan this QR code and connect with me at LinkedIn and happy to respond to any questions later on. Thanks, Shamari.
Thank you, Professor Rahman. Thank you for that informative presentation on the current status of tobacco use in Australia, especially the I kindly request all the participants to mute themselves while the presentation is going on, so that we do not have any background disturbances. And I also request them to put the queries, if you have any, in the chat box. We will be taking the questions at the end of the session. Sorry. So the status that you provided us about the tobacco use in Australia, especially the rise of e-cigarette and vaping among young people, that helps us understand that the issue is evolving into a new public health epidemic. As you already mentioned, that Australia had epidemic of the e-cigarettes and vaping. So even in countries like Australia, which have strong tobacco control systems, it is an epidemic. So in countries like ours, it is the scenario is more worse. So the public responses and strategy interventions that you shared and the policies that you mentioned, that all offered valuable lessons for all of us here, and especially for the ambassadors here who are with us today. They are working in tobacco control, especially in context of community of Nepal, rural communities of Nepal, where the similar trends are beginning to emerge. We really appreciate the global perspectives and the commitment to knowledge sharing. We'd like to thank you once again for joining us today. Thank you, Dr. Rahman. We will be taking all the questions regarding your presentation at the end of the session.
Sure, Shambhavi, thank you very much for giving me the opportunity. Before I allow the next presenter to talk, I would like to share also another opportunity for you to consider. So I am guest editing a special issue at IJERPH. So those who are publishing, so probably you are familiar with this thing. So it's a Q1 journal that has got the Q1 status recently. So I'm a guest editor for a special issue, so that is focusing on advances in prevention of control of non-communicable disease. So Prajwal and other colleagues at this forum. So if you want to aim for your next paper, feel free to consider this thing. You can scan this QR code, or if you search for this special issue, you will find this thing. So try to get this opportunity. Thank you.
Thank you, Dr. Rahman. Moving onwards, I would like to brief about Australia and many other countries where general practitioners, they serve as the first contact point for individuals who seek help to quit smoking. So general practitioners are they play the critical role in identifying the tobacco users. They initiate brief interventions, and then they connect the patients with cessation resources. So we have our second speaker, Dr. Masud, who will be presenting on smoking behavior and the cessation practices that are done by general practitioners. This will be presented on Australian perspective. Introducing Dr. Masud, he is a medical doctor, a PhD student at Federation University of Australia, and also teaches at University of Melbourne and Monash University. And he brings over 15 years of public health experience working in various countries of Asia and Pacific. He has been working in maternal and child health, adolescent health, and tobacco control too. So today we will be learning from him about how general practitioners in Australia, they're addressing the tobacco use through the structured system, the clinical guidelines, and moreover, the behavior change strategies. And we can learn this and adopt it in our countries to strengthen the frontline cessation efforts too. So, Dr. Salehin, we are pleased to have you. Please take the floor.
Can you see my screen?
Yes, sir.
Thank you. Thank you so much, Amori, for anchoring this event. So I'm Masud Salehin, a public health physician and a final year student at Federation University, Australia. And I'd like to thank my professor, Professor Dr. Muhammad Aziz Rahman, for giving me this opportunity, and specifically to Nepal Health Corps and Dr. Prajwal for hosting this event. Just a quick correction before I begin, Shambhavi. So I will not be talking about general practice nurses, but the general practitioners, the GPs per se. So the topic of my presentation is smoking behavior and cessation support by the GPs, the Australian perspective. So Professor Aziz has kind of set the context for me actually. So you all know that tobacco is the third leading cause of deaths and disability around the world. But then it is not unusual that healthcare professionals they smoke. But why do they smoke? I mean, we often forget that they are also human beings, and they're often influenced by factors that affect the general people. Um, it is not unfamiliar even in the earlier days. Nowadays, we use the word the sequencers, which is normally current days we use for the celebrities who portray tobacco smoking. But even in the earlier days, even in the earlier days, the tobacco industries are specifically targeted the doctors. Why? Because doctors' image was very useful for them, number one, and number two, to normalize smoking. So, is it important to know why healthcare professionals smoke and how much they smoke? It is because smoking cessation advice from a health professional has a positive effect on the patient and the community as a whole. And the WHO Framework Convention on Tobacco Control, FCTC, that is also specifically stresses the importance of healthcare workers setting an example by not using tobacco. There's also evidence that the professional position of the healthcare professionals may at times conflict with their own personal choice of smoking. So, however, given that context, the amount of information we have on healthcare professionals who do smoke is limited, and are often whatever we have are often based on information which are from either cross-sectional studies and which doesn't necessarily represent the wide spectrum of healthcare professionals in a region or setting. In Australia, it is not an exception either in this case. So, with that in mind, our first research question for my PhD journey was, what does the academic literature say about the prevalence and predictors of smoking among the healthcare professionals in Australia? So accordingly, we embarked on a comprehensive scoping review. We followed the ARCS and OMLA guidelines, and we used the 6 most commonly used databases, electronic databases. And as you can see from the Prisma flowchart, in the end, we were able to retrieve 26 articles which talked about smoking among the different health professional groups in Australia between 1990 and 2024. Now, who were the healthcare professionals that were identified in our scoping reviews? As you can see from this slide, so these are either physicians that included GPs, hospital physicians, specialists, nurses, which also have the registered nurses, the mental health nurses. Then we have the dentists, then optometrists. We had only one studies for the dentists, and of course the important component of the Australian healthcare workforce were the Aboriginal healthcare workers. So I've got some studies from as well. Now, if we look at this graph, it shows about over the years how the smoking prevalence among these different groups of healthcare professionals have fared. So this star marks is actually the national represents the national adult smoking prevalence in those years. In terms of, like I said, the optometrists, there's only one study of prevalence, only one. But for the physicians, it was 10.2% in 1990, which came down to 7.4% in 2013. Among dentists, it was 6% in 1993, which came down to 4.9% in 2004. If you can see the nurses, it was more or less similar as the national prevalence rate. But then into the 1990 note, it was 21.7%, which came down to 10.3% in 2014 and 15. The highest smoking prevalence, as you can see, is this, blue diamond, which represents the Aboriginal healthcare workers. And it was 63.6% in 1995 and coming down to 24.6% in 2021. Now, the Professor Aziz has talked about different tobacco control initiatives in Australia. So I have just tried to have them in order, in chronology, and I have tried to highlight some of these in red lines, which what I will try to do, I will not try to bring in those lines or those specific initiatives so that we can understand how this decline has happened or what are the major contributors. So if you can see, um, during this 1989, 1990, this period, so we have the National Tobacco Campaign starting. We have the reform of taxes on tobacco products, ban on advertising of tobacco products in national and print media. Then we also have the introduction of smoking ban in work and public places. And then here, from 2001, it was the extension of smoke-free policies in work and public places. And then the most important thing Professor Aziz mentioned about the Plain Packaging Act that was enacted in 2011. And since then on, all the things that were, major focus was increasing the tobacco prices over the years 14, 15, 16, 17. So this is how the prevalence have gone down, as you can see. However, from this picture, you can clearly see the proportion of decline was not proportionate among the different healthcare professionals. In terms of predictors of smoking, why the healthcare professionals smoke, as you can see, there are different biological demographic predictors or psychological or environmental predictors for the different health professional groups. For example, older age among nurses, or the male gender among the physician, nurses, and dentists being single, profession nurses smoking more than the physicians, or the specialty of the physicians who are engaged in emergency or ED or in the psychiatry, they're used to smoke more than they are than their counterparts. So there are lots of predictors which were identified in these included studies. We have published our this scoping review in the International Journal of Environmental Research and Public Health in early this year. What are the gaps from this review? So the healthcare professionals, they continue to smoke in Australia, and the current smoking rate also lower than the national average yet for some of the professionals. The declining trend is not proportional, as I have mentioned. And most important, if I quickly go back, you can see after 2014, we don't have any studies. So last study was identified in 2014. We don't have any recent data from the Australian context, unfortunately. So this brings down to our, this actually helped us to define with which population we want to proceed further and why we want to focus on the general practitioners. General practitioners are the cornerstone of the Australian healthcare system, as because 85% of the Australians, they visit a GP every year. And however, we don't have much knowledge about their smoking behavior. So with that in mind, the overall aim of my PhD journey was to explore the smoking behavior of the GPs in Australia. And the specific objective, first one we have already achieved, as I have shown, was the identify, see the, what's there out there in Australia in terms of healthcare professional smoking behavior. We did it through the first scoping review. The second and third study was a quantitative study. We wanted to see the prevalence and also how they are providing the support to their patients. So through two quantitative studies. And the final study, we wanted to have a more of a better insight into the smoking behavior and cessation support provided to the patients through a qualitative study. So the overall study design was a mixed method explanatory sequential study design. So for my quantitative study 2 and 3, this was basically a cross-sectional study which was hosted in online Qualtrics platform. GP clinics across Australia were my study sites, but we need to remember this survey took place during the extreme period of COVID in Australia. Although we were able to collaborate with RSCGP and also some of the largest GP conglomerate here. And also providing the circulating the survey among different social media platforms and doctoral networks, it was very difficult to collect in person because of the extreme lockdown situations across states and territories in Australia. So the results of my first study is when we went to see the prevalence of smoking. So 178 GPs actually took part in my survey, and more than half of the participants were male, and 68% were specialist GPs. And as you can see, the daily smoking prevalence was 7.3% among the GPs. So you can see Dr. Aziz just mentioned that the current prevalence, national prevalence is 8.3. So GPs are not very far. And if we add the occasional smoking rate, which will give us the proxy current smoking rate, it will be more than 11. So this is quite concerning. In terms of what is their preference, as you can clearly see, cigarette was the most preferred form, followed by vaping, and some of them also use water pipes. Now, why did the GPs smoke? I mean, some of the GPs and most of the GPs they mentioned that to get relief from anxiety or depression, or it was something separate from their professional duty, or due to social or peer pressure. Now, in terms of the quitting behavior, although 95% of the ever smokers they attempted to quit, only 15% did so in the last preceding year, and out of those, only 59% were able to remain abstinent for more than 6 months. In terms of what did they use to quit smoking, so prescription medication was obviously a major tool, followed by vaping. So as you can see, vaping is kind of a harm reduction, but also taken up by the GPs as well. We use two scales: motivation to stop smoking scale, and also the smoking abstinence self-efficacy questionnaire scale. And based on this two scale, we have found that the current smokers only had the desire, but not the intention to quit, and also the ever smokers had a moderate self-efficacy to quit. In terms of predictors of current smoking among the GPs, we have found that the GPs who are older, or the male GPs, or the GPs who are smoking for more than 10 years, are more likely to be current smokers. So the key messages from my first study was that the GPs in Australia are not immune from smoking. As you can see, 7.3% were smoking, but the current GP smokers lacked strong motivation and self-efficacy to quit, and we need to have tailored smoking interventions for them. Going to the second study, where we try to identify the smoking support to the patients. So we have seen the Royal Australian College of General Practitioners advised the 5A tool, which talks about in the 5A will ask about the tobacco use, assess willingness to quit, assistant quit attempt, and arranging follow-up. So we have found that in terms of current GP smokers, when we compare them with the never smoker GPs, we have found that they are less likely to consider or conceive the GPs serve as role models, or patients' chances to quit increases if GPs advises do so, or GPs who smoke were less likely to advise their patients to quit. And also importantly, current smokers were less likely to be familiar with the 5A smoking cessation tool. In terms of always implementing the different components of 5S consistently implementing, you see the level of implementation was not optimal at all. The highest was 28.7% asking and follow-up and assisting only about just over 20%. Concerningly, 4 out of 5 GPs did not receive any specific training which would allow them for smoking cessation counseling. Interestingly, only more than nearly 2/3 of the GPs were spending less than 2 minutes to talk about cessation support. In terms of the barriers identified, it includes both the supply side and demand side. The GPs mentioned the patient raises advice on talking smoking, or there is no clinical time, and what isn't there for me, no reimbursement. And some of the GPs also fear that if they do talk about cessation, they might lose patients. So the key messages from my second quantitative study are: so utilization, as we have clearly seen, of the cessation tool is not optimal. The perceptions of the practices of the GPs in regard to cessation is very much moderated by the smoking behavior. And of course, the GPs will require skill building training, which will allow them to negotiate with their patient in terms of smoking cessation. And we need to consider the socio-demographics when we design the cessation programs for them. Now, you might be a little bit concerned why I wish to talk about migration. Smoking among the migrants has become a very important discourse in recent decades. And despite a bias which has occurred in our sample size, as we have found that 90% of our GPs are actually migrants. We had to shift our focus to migrant GPs as well. And this is also unique considering the uniqueness of the Australian healthcare system, where more than 32% of the GPs here working are overseas trained. And because of a shortage of health workforce, they constitute a significant number, and this will remain to be a thing in the future as well. So, with that migrant thing coming in, we had to modify our objective 3 and 4 a little bit, because now we wanted to explore what we know about the smoking about among the migrant healthcare professionals on a global context. And also, since we already have the information about the migrant and non-migrant GPs, we wanted to see whether there's any difference between these two groups of people. And finally, we kind of modified to get the better insight about from the GPs in terms of decision support. We thought that it would be better to do it amongst the migrant GPs. So the rest of the things remain the same. So result of the second scoping review among the migrant healthcare professionals, it revealed that only 2 studies. So the one showed 16% prevalence among the male Indian physicians, another one showed only 0.6% smoking prevalence. The gap that was being showed from that review is the absolute dearth of research, and the studies were conducted in the USA only among the Indian immigrants, so not necessarily represent the other physician group, and those were conducted in the early 80s and 90s. So in today's context, doesn't have any bearing. So based on that, as I mentioned, we wanted to explore is there any difference between the migrants and non-migrants? But however, our study revealed that actually there is no statistical difference between the variables and the migration status of the GPs in terms of their current or reverse smoking, types of smoking, or the quitting behavior, the perceptions on smoking support, or the use of 5 brief cessation tools. There is no statistical significance between these two because of the obvious skewed data in our sample for the migrant GPs. Of course, migrant GPs are smoking more, like 6.1%, but that needs to be interpreted with caution. However, based on the motivation to stop smoking scale, we have seen the current migrant GPs had better intentions to quit than their non-migrant counterparts. So the key messages from this third quantitative study is that migrant GPs, they also smoke. However, there are no significant differences between the migrant and non-migrant GPs. So the smoking cessation interventions, when we wish to tailor them, they need to also include the migrant GPs as well. And we need to do further in-depth research, which will be on a larger and representative GP sample. So all of this has led us to the final qualitative study where we wanted to really explore what underpins the behavior of the migrant general practitioners after migration and how their smoking behavior would define their perceptions or cessation practices in the new society. Accordingly, we opted for this qualitative design. We conducted 10 in-depth interviews and conducted the thematic analysis. And this analysis actually came up with 5 broad themes, which were migration, smoking and migration, interplays between professional imaging, smoking cessation support, walking the talk, implementing the 5 A's, barriers, and facilitators of 5 A's implementation. Now, these 5 sub-themes and 14 sub-themes identified actually showed that the change in smoking behavior of the GPs after migration are mostly triggered by the high tobacco price, as mentioned by Professor Aziz and my scoping review, and also the loss of peer connectedness in host country. And these changes could be explained by either the healthy migrant effect, which is, of course, Australia employs a scale migration visa system. There's a point system, so we can easily contextualize the background of the GPs coming from overseas, or through the Becky's acculturation framework, which kind of describes how a person adopts the culture or picks up a culture of their host country over a period of time. So also this exercise showed us that both migration and the change smoking behavior affected the perceptions in terms of cessation support, and some of the barriers identified more or less common with the quantitative study, but again they also highlighted the lack of training, missing incentives as or smoking is not being a priority agenda seen by the migrant GPs as well. So the key messages from the Squall study is that we need to understand the cultures that influence the migrant GPs, why they smoke, and how it influences the duty bearer role. And also, we need to further assess their opinion to develop a responsive and comprehensive 5-year implementation strategy in Australia, as we have shown that it is very much not optimal yet. So the final one, very final slide, is the overarching recommendation. So we need to tailor the smoking strategies for GPs because they're still smoking at a higher rate. We need to really enhance the access to cessation support sources. When you talk about access, it's not only quick line because patients always say it's busy, 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 or the pharmacotherapy that Professor Aziz talked about. Some of them are not in the pharmaceutical benefit scheme because it involves a lot of money. So people need to take it for a long period of time. So increasing and enhances access is required. Of course, as identified time and again, the GPs need compulsory training, which will help them to equip them with negotiation skills with their patients in terms of cessation talk. They need shared accountability in the GP practice in Australia. There are practice nurses as well, so how they can be brought on board and kind of do this share responsibility. Time and again, it came up that then what's there for me? What's there for me? That is a different item code. I don't get incentivized. I don't have time. So if possible, how can we, incentivize the GPs to take it as a separate topic and spend a little, not only less than 2 minutes, but a little bit over time, a bit more time, so that it is productive. And finally, we need to have collaboration between the different bodies. Like the Royal Australian College of General Practitioners, the Australian Health Practitioner Regulation Agency, Medicare, and the GPs of the healthcare providers as a whole. And finally, of course, we need more, up-to-date data for cessation support because something continuous. So with that, I end my talk here. So if we have got any questions, so I'm very happy to answer at the end of after Dr. Nimmi's presentation. Thank you so much.
Thank you. Am I audible? Hello? Hello, am I audible?
Yes, you are audible,
Yes,
Sambhavi.
you
Go
are.
ahead.
Yeah.
Thank you, Dr. Salehin, for sharing the findings of your study. So your presentation offered a valuable look into smoking behaviors and the cessation practices of general practitioners themselves in Australia, which is the perspective that we often don't hear. It was particularly new for me to learn that some healthcare providers that themselves engage in the smoking, which understandably affect both their ability and willingness to counsel the patients on cessation too. So your research have highlighted an important dimension of tobacco control, how the personal behavior and the perception of health professionals can directly influence the public health outcomes. So this is a reminder for all of us that tobacco control is not just with the public, but with the healthcare system ourselves and health professionals ourselves. Thank you once again for setting light on this critical issue that is often overlooked in the aspect of tobacco cessation. Thank you, Dr. Salehin. So we have our final speaker for today, Dr. Naima Nimmi. She is also a PhD candidate at Federation University, Australia, who is specializing in adolescent vaping cessation and healthcare provider engagement. Today, she will be presenting us on the topic vaping among adolescents, preventive and clinical support by general practitioners and pediatricians in Australia. So with the rapid rise in e-cigarettes and vaping among the adolescents and young people in countries like ours and countries in Australia where epidemic still exists, and where a country like ours is facing a new public health challenge because of this. So vaping products are often marketed as safer alternatives, and yet they are also bringing a lot of health issues, and especially among the young people, they are neglecting the health issues that are being caused by tobacco use through these vaping and e-cigarettes. So I hope Dr. Nimmi's insight can help us develop the effective adolescent health responses in Nepal and beyond. We are honored to have you here, Dr. Nimmi. Please, I hand over this floor to you. Thank you.
Thank you, Shambhavi. I'll just share my screen. Give me a few minutes. Is the screen visible?
Yes.
Yeah, thank you. So, hello everyone. I'm Naima Nimmi, a PhD candidate from the Federation University, Australia. I'm the final year student. And thanks for Professor Aziz and Prajal for giving us the opportunity today to talk and for organizing this wonderful opportunity to discuss my research. So the topic I'm working on, that is vaping amongst adolescents, a preventive and clinical support by general practitioners and pediatricians in Australia. Before going to the study findings, let's have some background information, why this research and what's the importance of this research. Let's see what are the prevalences. In the decreasing global trend of cigarette smoking, the use of other tobacco products increasing, and it's recognized as a growing global health concern. Global lifetime and current prevalences, if we want to see, that is 25% and 11%. E-cigarette poses a serious health risk to adolescents. According to the latest National Drug Strategy Household Survey in Australia, says that around 1 in 5 Australians aged 14 and over reported having used an e-cigarette at least once in their lifetime. And around a quarter of the students who had used e-cigarettes before ever smoking reported later trying tobacco cigarettes, which is very concerning. Another study that is from one of the states in Australia, that is the New South Wales, they found that a substantial raised number of prevalence, what shows a lifetime prevalence is 32%, of them were never smoker, were 58%. So you can see in state-wise, the numbers are different. So what is an e-cigarette? E-cigarette is a distinctive group of battery-operated handheld device that vaporizes liquid solutions when heated to a certain temperature and the users inhale using a mouthpiece. I believe most of you know of these e-cigarettes. And you know these projects come into the market just a few years, you can say. In 2007, it came into the market. And these products has been changed rapidly, not only in their design and technology, but also in their solutions. So most e-cigarette brands are owned by the big tobacco companies. They are targeting vulnerable adolescents and young people with flavoring attractive packaging, and obviously their tactics of the advertising and marketing, what they have used for a traditional cigarette. In the image, what you can see is the transition of the generations, and the newer generations are very popular because of their shape and size, as they are easily concealable. It can fit anywhere, in the pocket, in school bags, everywhere. So these products are hugely using among the school children of Australia as well. And what are the risks for adolescents? So we all know this population group is commonly involved in risky behaviors, including experimentation with substance use, and this device is only kid-friendly flavor. So according to WHO, there are, you can see there are 1,600 varieties are available in the market, and there are plenty of options to choose. So now I want to come into the point that what is in this vapor? Is it only water vapor? No. Firstly, I want to mention there is nicotine. Whatever the label says, there are nicotine present in all of the vape liquids. So, and almost this all nicotine, like whatever the label is saying, it contains nicotine. And we all know that nicotine is highly addictive and can harm the adolescent's brain development. And it can also harm the parts of the brain that control attention, learning, and mood. Using nicotine may also increase the risk of future addiction to smoking and other drugs. Even if there is no nicotine, a range of harmful substances present in the vapor. flavoring agents, volatile organic compounds, and there are ultrafine particles as well. And flavoring agents are related to lung disease. So I want to mention that there are a couple of laws has been implemented, which Professor Aziz has also mentioned. So the last, after the new laws, which has implemented 2024, the way Australians can access the vapes has changed after that laws. So vape can now only be sold in the pharmacies, regardless of whether they have nicotine in them or not, doesn't matter. Then non-pharmacy retailers such as tobacconist, normal vape shops, convenience stores, they cannot sell any type of vape. And if I have mentioned that there are 1,600 varieties of vapes, but now the flavors in vapes are restricted to Australia just on to three flavors, that is the mint, menthol, and tobacco. And also there is a ban on the advertising and promotion of vape. So you can see that Australia has done a lot of implementation of laws for the vaping issue. Now, why I have chosen healthcare providers? We all know that healthcare providers are the reliable and trusted source of information and preventive services for adolescents. And studies establish that healthcare providers' counseling can increase the quit rate for smoking, and it can also influence the change in other tobacco-related behaviors by helping them to reduce tobacco consumption and cessation. In Australian context, healthcare providers, I have chosen GPs and pediatricians because GPs are the primary clinicians or healthcare providers for adolescents in Australia. They are often the first contact for adolescents, we can say for anyone. And for pediatricians, pediatricians are also in a position that they can provide targeted education and support during the routine checkups for the adolescents. So after an extensive literature review, what I found that there are scanty evidence of healthcare providers' views on vaping devices other than it's as a smoking cessation aid. So we have conducted a scoping review to find out, and we started with 1,387 articles, and finally we included 14 studies, and where I have found that healthcare providers had limited knowledge of e-cigarettes to support adolescents in vaping. They have several barriers to providing vaping cessation support, and they have inadequate screening and counseling for the adolescents vaping. And there is also lack of understanding of the importance of discussing vaping. So we have actually recently published our scoping review. So please, if you're interested, you can scan this QR code and you can get the full article, and in your convenient time, you can have a read. So that's why I'm not going in all of these findings and everything. So what we have found in our review, that studies focused on healthcare providers were entirely, most of the articles were from US, just one was from Australia, and moreover, they were not exclusively on adolescent population. So we have conducted a mixed method study, exclusively investigated the views of healthcare providers focusing on supports for adolescents vaping in Australia, which includes a qualitative and quantitative part. So today I'll discuss about some of the quantitative part, and I'll share some findings too. So the research question was, what is the knowledge, attitude, practices, and barriers of GPs and pediatricians regarding vaping cessation support for adolescents in Australia? So our study is a cross-sectional in design study, and we got the ethics approval from the Ethics Committee Federation University Australia. And the data collection started based on an anonymous online link web-based questionnaire, and which was developed in Qualtrics. Recruitment of the participants where we have actually approached to multiple networks. We sent invitations, email invitations to primary healthcare networks, then professional societies. We also invite the head of departments of general practice in different universities. We also used newsletters, then social media, WhatsApp, Viber, and invitation through text messages. So after all of this, we actually found like we have 655 responses. However, we could only include 546 because they were complete. So what tools we have used? So a structured questionnaire was made to assess the knowledge, attitude, and barrier, which has been prepared after an extensive literature review and tested among GPs and pediatricians before disseminating through the Qualtrics. And the WHO 5A tool is a standardized tool on 5A, which include ask, assess, advise, assist, and arrange. And 5A is commonly used for used to guide smoking cessation, and can also be recommended, can be used for vaping. So we have used for assessing both the smoking and vaping behavior. Now the study settings. So we were lucky that a statewide sample have achieved from all the states and territories from across Australia. In that pie chart on the top, you can see the representation of the statewide sample. And among the clinicians, most of them working in the private practice, almost 77%. The other work setting of the practice of the clinicians were hospital and community health center. And 67% were practicing in the metropolitan areas. Now, if the population, so I have already mentioned the participants of the study were practicing GPs and pediatricians of Australia in the metropolitan, regional, and rural areas. And total sample size was 546. 83.5% were GPs and 16.5% were pediatricians. And 75% of the clinicians had their primary medical degree from Australia. However, there are 25 other countries like UK, India, New Zealand, Egypt, Bangladesh, and many more countries were listed for the other clinicians' primary medical degree. 69% of them were female, and 94% had seen an adolescent patient last month. Now, I will start sharing some of the findings. I'll start some findings that is only GP, like general practitioner focused. In this bar chart, you can see that we have asked 9 questions to assess the knowledge. The questions were, what are the types of e-cigarette, nicotine content of e-cigarette, addictiveness of e-cigarette, this sort of questions. And so their knowledge, in that chart, you can see that their knowledge where most of them lacked in several components, except that addictiveness of e-cigarettes. Among all of the components, they are lacking knowledge, but I want to highlight that the GPs were unsure about the nicotine content, chemical content, and the treatment and referral process for e-cigarette cessation support. When it comes to the practice, with the 5A questions, these blue bars are representing the clinicians' good adherence to the guidelines for offering vaping cessation support. We can clearly see that except advising adolescents, the other 4 practices like asking about the e-cigarette, assisting, and even arranging was not that common. Now, I will start discussing few of the significant findings from the multivariate logistic regression analysis. We tried to look, is there any differences between the older GPs and compared to the younger group? So when I'm saying the older GPs, I'm meaning the age that is 50 to 60 or more. And when I'm saying that's younger GPs, that is less than 30 to 49 years. So what we found that older GPs are more knowledgeable on chemical composition of e-cigarette, but they are less likely to discuss vaping with adolescents. They also more likely to arrange the follow-up visits for cessation support, and they face the referral barriers. I mean that like they do not know where to refer adolescent patients when they are asked for vaping cessation. Now, we also looked in another perspective among the metro and non-metropolitan general practitioners, also among the female and male general practitioners. So metropolitan GPs are more likely to recognize that e-cigarette types, and they have more knowledge gap, but they have more knowledge gaps compared to the non-metropolitan region GPs. And metropolitan GPs have more referral uncertainties than the non-metropolitan GPs. If we go to the female GPs, that they are less likely to believe that vaping is safer than smoking, and they are also less likely to arrange follow-up for smoking. Now I'll start sharing some of the findings that is pediatrician focused. So in the bar chart, you can see that we have asked that same 9 questions to assess their knowledge. Unlike GPs, pediatricians have not only knowledge on addictiveness, also higher percentage of in different components as well. Again, so we'll discuss some significant findings from the multivariate logistic regression analysis for the pediatricians. Again, it's older versus younger and female versus male. So older GPs are more knowledgeable on chemical composition, but they are less likely to know the treatment option for vaping cessation. Then again, female pediatricians are less likely to believe that counseling will reduce the adolescent e-cigarette initiation, but they are more likely to face the referral barriers compared to the male pediatricians. Now I'll share some findings that are in a different angle. That we try to look, is there any difference between the GPs and pediatricians in terms of knowledge, attitude, practices and barriers? So in terms of knowledge, GPs are 3 times more likely to know about the 5A model for talking to patients about e-cigarette use than the pediatricians. But 59% of GPs are less likely to know about the nicotine content of e-cigarette compared to the pediatricians. If we want to know about the attitude, it came up that 2.6 times more likely to believe that e-cigarette are a potential gateway to tobacco and other substance use than the pediatricians. And in terms of practices, we also found that GPs are less likely to arrange follow-up visits for adolescents than the pediatricians. And for the barriers, we also found that 57% of GPs are less likely to offer vaping cessation support due to the lack of time within their clinical visit compared to the pediatricians. And they are 3.7 times concerned about the confidentiality issue of adolescent patient. They think that as a barrier, that why they don't provide vaping cessation support compared to the pediatricians. So what the key messages are that the clinicians need more up-to-date training on vaping cessation. Clinicians better strategies to ensure the follow-up with the adolescent patients. And clinicians need a standardized, clearer guideline on where to send these adolescents for vaping cessation support. And we also need that we should routinely ask adolescents about vaping alongside with smoking during consultations. So I think a question will come on your mind that how equipped are you both clinically and systematically to support adolescents vaping cessation in the Nepalese context? Because of the time, I didn't complete all of the findings which I couldn't share. And thank you for having me. And if you want to connect in the LinkedIn, this is my, you can scan this QR code.
Thank you, Dr. Nimmi, for sharing the findings of your important study. This offered much needed look into the preventive and clinical roles that general practitioners and pediatricians they can take in tackling the adolescent vaping, which is a rising concern in many countries. So what stood out to me was the gap in knowledge and the preparedness that healthcare providers themselves have regarding the e-cigarette cessation support, something we definitely need to strengthen. So while giving sessions in Nepal also, we have found that vaping and like hookahs, they are taken too casually, even by the parents of the students. During some of our awareness session, I have heard children say that their parents told them that vapes and e-cigarettes, they are just flavors and they're harmless. And some of them have even encouraged their children to try it in the family function. So they do not recognize that it has a risk of nicotine addiction too, and it is harmful too. So I think your insights are the reminder that we need to work not just with the adolescents, but also we need to educate the parents and the healthcare providers to address this growing issue. Thank you once again for such a relevant presentation. So moving on to
Thank
the
you so much.
last section of our webinar, we will now open the floor for questions from our participants. Please feel free to type your questions in the chat box or even raise your hands and we will unmute you to ask the questions directly to the presenters. Or if you have any questions regarding our recent anti-tobacco campaign that Nepal Health Corps is organizing, then also you can kindly unmute yourself and ask the questions or feel free to type the questions in the chat box.
Probably people don't have any question. Rather than I can ask some questions to Prajwal to give us a little bit of context of Nepal or Sambhavi, if you can let us know, because sorry for our ignorance. Really, what's happening in Nepal? So, where is the biggest gap in tobacco control strategy there? If you can tell us a little bit of highlights, what are the main challenges that you are facing, so we can get a bit of context.
So Sambhavi, are you presenting, right? Do you have slide?
So, I have the slide of our tobacco campaign only, but I think
Yes, that's just show the the outline of that campaign, and I'll share some of the challenges.
okay,
Yep,
sir.
thank you.
Is my screen visible?
Yes, we can see it. Can you make it a little bit large, please? Yeah, thank you.
So this is the campaign that we are doing right now. This is initiated by Nepal Health Corps in collaboration with World Federation of Public Health Association. As I already mentioned about our organization, we are the network of young health professionals and students, and we are committed to achieve a health equity and universal health coverage by 2030. Our flagship program is Ambassadorship Program, where we choose health science students, medical students, nursing students from each medical colleges, public health schools, and nursing colleges. And then we provide them sessions, trainings, and encourage them to do grassroots level leadership and community health activities. Our vision is to create a healthier and thriving community through accessible healthcare facilities. And then talking about our campaign's objective, it is to educate the young students on harmful effect of tobacco consumption. We are targeting the students from grade 6 to 12 from schools from all the provinces, all 7 provinces of our country. We empower the young volunteers to become health advocates in the community. And we are creating a sustainable movement actually through social media and then grassroots awareness sessions. And also we are collecting data. We are conducting a research on the status of tobacco consumption and the factors that are hindering the prevention of tobacco consumption among young people. So this is our previous data, but right now we have reached 66 plus schools, conducted more than 70 sessions, and have reached students, more than 6,000 students of more than 66 schools, and have conducted more than 55 social media campaigns. So we have our outcomes as positive shift in students' attitudes, and then we are engaging young people here. We are creating a ripple effect in the community and school. These are some of the photos of session being conducted by our ambassadors at different parts of Nepal. And we are also creating a social media movement where the people who get into our campaign have to share this poster in their socials, saying, I commit not to use tobacco and promote a healthier tobacco-free lifestyle for myself and my community. So this is the movement that we are running in the social media. So yeah, this is the brief about what we are doing from Nepal Health Corps. We have also celebrated World No Tobacco Day, conducting rallies at 3 different places of our country, Kathmandu, Chitwan, and Pokhara, with the involvement of World Health Organization. We did walk the talk with the ambassadors, health advocates, and conducted a short awareness program in Tribhuvan University ground. So yeah, these are the initiatives that we are taking till date.
So Aziz, yeah,
I've got a few questions, sorry, if you allow me.
yeah, please go ahead.
Sure. Thanks, Shambhavi. So, yeah, it looks so good that you are doing these awareness sessions to the youth ambassadors and this championship campaign and so on. So, just a quick question is uh, because I've been involved in this sort of activities in the past, not necessarily with tobacco cessation, but with other health issues and so on. But the problem that we have encountered that so in regard to the sustainability of these issues, like for example, so we have this one awareness session in school X or the Y places. So how frequently they do take place, and like after 6 months, how you are making the connections, what the ambassadors are still doing. So like, is there a network or there's a peer support group? So how they continue to do their work in the community when you are not there anymore, or the health corps is not there anymore. So how this continuum is actually going on, because often they are lost after these awareness sessions, from my previous experience. And tobacco smoking being such a complex issue.
So we have we have 2 phases of this program. We are on the first phase. In the first phase, we are doing this tobacco related awareness sessions. In the second session, in the second phase, we will be creating peer support groups. So we will be connecting them with the local government, and we will be conducting sessions in collaboration with them. And we are also planning to get support from Ministry of Agriculture and Ministry of Health, so that we can sustainably run this project. After the ambassadors train the students of the different schools, we are also choosing two tobacco control advocates from those schools, and we will be creating a group under them, and those students will be responsible for further conducting the sessions, and there will be monitoring and evaluation from our side. But for sustainability, we are creating peer support groups, and we are giving the leads to the best presenters, the school leaders to conduct the sessions in future.
Yeah. Thank you.
And in terms of tobacco cessation support, so what is the availability of resources? Is it just the awareness raising to stop people to uptake smoking, or is there any? I'm pretty sure the pharmacotherapy probably is not available there. What about counseling, or is there any other facilities there?
Yeah, Aziz, recently, the Ministry of Health and Population Government of Nepal has started the helpline services,
Oh,
in
good.
context of Nepal. Recently, on the World No Tobacco Day, they initiated this initiative in Nepal. And as said by somebody earlier, that Nepal became the first country to do 100% pictorial warning. Yeah, that is, they also what they were the country was also awarded in the WHO Assembly recently, and our minister took that award from Nepal. So Aziz, our point is, what I think is in context of Nepal and in the global context, we have a lot of laws, regulations, so, a lot of things have been done, but the implementation part has been very poor. So I think the Nepal Health Corps is doing that thing. We are trying to create, in the first phase, we aim to reach around 10,000 school going students, because if we have to start in the primordial and primary prevention, we have to start from schools. So that is our plan. So that and then we are collecting the data as well. So if we have a data in the second phase, we will design the interventions. So what interventions will work in that particular province, then we will design that interventions, and we'll start connecting with the local governments, and try to get fundings from the local governments, and try to sustain that. And additionally, as said by somebody, we are also trying to conduct a dialogue with Ministry of Health and Ministry of Agriculture on tobacco farming. So we are thinking from that perspective also. So any sort of earmarked fund, if we can generate through Ministry of Health and Ministry of Agriculture, and we can also think of alternative source of income for those farmers who are doing tobacco farming, and stop and start, just starting, in the initial phase. And recently, the mayor of Kathmandu metropolitan city, the capital city of Nepal, he initiated this the anti-tobacco campaign, ban in the Kathmandu metropolitan city. But there was a again, the tobacco industries put, there was a it was in the court now. Still it is ongoing. And I think we have to find out what how the tobacco industries put all these things together, and beat in the court, because they are very fast powerful too, with the politician and
True.
everything.
Yeah.
So we are trying to do, but it's not that easy. Yeah.
And what's happening with vaping?
uh,
How commonly available it is there, and
yeah.
what about
So
the cost?
Yeah, cost, I don't know exactly. I think the young colleagues might be knowing, but when we were trying to do this sessions in context of school, and I found school students, they are carrying the vapes, and they are carrying the vapes, and when we give the educations, and they start pointing out that this guy takes the vapes, in that way, we know that somebody is taking vapes in that classes, so the exact cost, I don't know. I have to figure out. So maybe anything you
But
have,
do you
about.
know where do they get this from? those
Uh,
vaping products, the school children? Because in Australia, why I'm asking this thing, because the same thing is happening in Australia. All the school children started taking the vapes, and there are lots of studies on there. And why I'm asking all of these questions, so probably we can think of some joint collaboration and collaborative research. So we can do some research if there is no evidence on there. So about the adolescent and vaping, and then the same thing will come to Masud's project about the healthcare provider. What about the smoking there? So I'm pretty sure the situation is probably the same there. So we can definitely think of doing some collaboration there.
Yes, yes, yes. I don't think we have done much research on this vaping, in context of Nepal. So although recently when we have an interaction with WHO, WR, recently we had interaction with him, and they were also focusing on these vaping products,
Mm,
and
mm.
I think very few research has been done. So I think this will be a good study if we can collaborate together. Yeah.
And what about, do you have any studies so far? Because when Masud showed his presentation, the Global Health Professional Service, so that was really initiated from WHO long ago. So probably Nepal was part of this thing. But do you have any idea whether there was any recent study or any study that focused on the smoking behavior of the health professionals in Nepal?
So recently, I don't know, Aziz, but when I was doing, my medical studies in eastern part of Nepal,
Mm,
and we found,
mm.
there was, I think there was few studies that, we found that a lot of medical students in the medical colleges, they smoke, and I think there is some papers also. Then I will share you, if I
Mm,
found some.
mm.
Yeah, there is some papers.
Smokeless tobacco is very popular in Nepal, isn't it?
So yes, it is very popular. Yeah.
Mm.
So in the form of, I think in the you on the all understand this kainis, kainis,
Yeah, yeah,
and
yeah,
they
yeah.
put in the
Mm.
so this is available, and all sort of this mixed products like this, adding sweetened beverages and something like that, and so it is commonly found in context of Nepal. Yeah.
Yeah.
What about dual or triple use of this thing? Those who are using smoking, vaping, and smokeless tobacco product, because it is really um,
Uh,
three issues that probably people are using.
uh, so yeah, I don't know. I don't think there has been much research about these things. Okay, so smoking, smokeless tobacco products, and vaping,
Mm.
but I found a lot of school teachers, and they use a lot of school teachers in the schools also. They use a lot of the smokeless tobacco products. I've seen a lot of
Yeah.
teachers school in the using the school. So I think we need research, Aziz. We need more research on this aspect in context of Nepal.
What
Yeah,
what we hear
and
from you and somebody about this, your network of this Nepal Health Corp. So you already have this group of young professionals, and you also have the network. So I think if we can plan a couple of projects, so it's possible to do this thing, and all three of us will be really keen to support you and collaborate with Nepal Health Corps. And whatever we can do, we can definitely provide you the research expertise from here, and whatever the way that it will be helpful. So we'll be really keen, because really, as a researcher, we need to generate evidence, and definitely we can share our expertise to do this thing. So you already have this network. We can just make a plan for, say, for example, if we even can do one survey, within one survey, we can include all of these issues: smoking, smokeless tobacco, vaping, and then we can do separate analysis. And we have extensive network. So that is a benefit that we can think of planning.
yeah. So I think Nepal Health Corps has a big network. I think they have around 5,000 green members.
Mm.
5,000 green members, as well as they are distributed in all medical and public health universities in Nepal. So I think yes, Aziz, we can do a little bit of guidance to these young colleagues. I think they will deliver.
Just curious to know about these young people, those who said about these 5,000 Nepal Health Corps. Do they use any tobacco product?
Exactly. I was thinking the same question,
I use the director of Nepal Health Corps is
because
here. I think
it would be a
answer
wonderful
this.
study example.
Yes, that's the thing. 5,000, we can do the study on them first.
Ayush?
Ayush,
Yes, sir. Uh,
do you know from learning to
Pardon, sir, I could
experience?
not hear you properly, sir. But this is something about Nepal Health Corps. Could you please repeat the question, sir?
The question is, as Prajwal has mentioned, so in the Nepal Health Corps, probably you have 5,000 volunteers, right? So extensive network. So we are asking, among those 5,000 people, do you think that these people use any form of tobacco products?
Yeah,
Smoking,
being honest,
smokeless, vaping?
they use, sir. I cannot guarantee it, but I know, being a medical student myself, and seeing a lots of students, juniors, and even higher professionals, they used to, consume tobacco and other and every form of tobacco, indeed. So yes, sir, it would not be. I would be honest, they do. But yeah,
Okay,
as
here you
said,
are.
that we could conduct students, we could conduct research in this team as well, to find out, probably what is the real scenario of medical students all over the Nepal, because our team already represents each and every medical colleges of the country. So we can like conduct the study in this organization itself to replicate the overall picture.
Excellent. I think that's a really that will be really good study to do this thing to start with them, because really, again, if you reflect on the study that Masud has shared and Nimmi has shared, so you are trying to create the ambassadors who will really provide the awareness on the smoking cessation. Now, if I am a smoker, how motivated I will be to tell people, "Oh, don't smoke," because it's conflicting with my attitude, right? So it's important to know about those volunteers, about their tobacco use habit, and then probably that will give us some information. Say, for example, as Nimmi and Masud has presented, probably they don't know really what to do, or they really need more support. So there will be some evidence, and definitely we can publish this thing. So think, Prajwal, in that way, if we can do, probably that could be the starting point to do.
Yes, yes, I completely agree, Aziz. We can do that, I believe. Yeah.
Excellent. Okay. Okay, I think it was really a good session, and I can see there are opportunities that we can work together. So probably moving forward, it would be really good, Prajwal, to set up another time to think of really what is the immediate possible thing after this. And one of these things that came up is about doing a survey among volunteers of Nepal Corp about vaping, about smokeless tobacco, and some of the tools that Masud and Nimmi has used already. Those are validated tools, so you don't need to reinvent the tool. So we can block a time to look at those tools and then make a plan. Okay, this will be the tools, this will be the questionnaire, and then we can start with these things. So probably it will be good to set up a time in a couple of weeks to sit together to make a plan and then go from there.
Yes, yes, Aziz, we will do that. I think Samabi will coordinate that, and
Yep,
and she will communicate with you in the WhatsApp, and
sure.
try take time, and we will discuss and plan accordingly, Aziz. Yeah.
Wonderful.
Yeah, thank you once again to all our esteemed speakers and all the participants for being part of this insightful session. So before we close, if we have any more discussions to do, the floor is open. We will give a minute of time for the participants to share their questions or queries if they have any. Otherwise, we will be concluding our today's webinar on tobacco control, challenges and opportunities in global health.
So I think Samabi, one group photo. I think we should take one group photo, I believe.
Yeah. Meanwhile, we will be taking group photos. So I request everyone present here to turn on their cameras so that we can take a group photos and share in our socials later on. Also, I would like to notify that the session has been recorded, and then we will be sharing the session's recording in our socials. I request all the participants to turn on their videos so that we can take a group photo, sorry. So thank you everyone for joining today. With this, we would like to officially conclude our today's webinar. We hope today's dialogue has inspired everyone for the continued learning and collaboration and action to fight against tobacco-related harm, both in Nepal, in Australia, and in global health. Thank you once again and have a wonderful evening ahead. Thank you for the speakers once again, and we are looking forward to connect with you and learn more from you. Thank you.
Thank you
Thank you,
so much.
everyone. Thank you. Bye-bye.